I'm Dr. Raajit Rampal from the Memorial Sloan Kettering Cancer Center in New York, and today we're going to be talking about the current state of treating polycythemia vera. Retrospective studies of patients with polycythemia vera have demonstrated that patients with PV do have a decreased lifespan as compared to the general population. As well, there is a risk of thrombosis, which represents the most common sequelae of polycythemia vera. The estimated 15-year risk of thrombosis is approximately 27%. As this represents one of our major concerns in the management of patients with polycythemia vera, risk scoring systems have been developed to stratify patients' risk of having a thrombotic event. Patients are deemed to have low risk of a thrombotic event if they're under the age of 60 and have had no history of a thrombosis and have a platelet count of less than 1.5 million and no cardiovascular risk factors. Patients are deemed to be high risk for a thrombotic event if they're over the age of 60 or have had a previous thrombosis. Some patients do fall into the intermediate risk group, in which they are deemed to be neither low risk or high risk. Beyond the risk of thrombosis, patients with polycythemia vera can have substantial symptoms. The total symptom score was developed to categorize patients' symptoms and to quantify patients' symptom burden. Patients with polycythemia vera can have a number of different symptoms, including fatigue, pruritus, and myalgias. Interestingly, patients' symptoms can be clustered into different categories. Patients with mild PV may have only fatigue, whereas patients with high PV cluster scoring have high levels of fatigue, insomnia, early satiety, and abdominal pain. Keeping these things in mind, our major goals in the treatment of PV really are to reduce the risk of thrombotic events and also to attempt to reduce a patient's symptom burden. How can we achieve these things? We have several modalities at our disposal, including therapeutic phlebotomies, cytoreductive therapies, using drugs such as hydroxyurea and interferon, utilization of JAK inhibitors such as ruxolitinib, and antithrombotic modalities such as the use of aspirin and lifestyle modification aimed at lowering cardiovascular risk factors. Data with regards to the use of aspirin has demonstrated that aspirin, as compared with placebo, is associated with a lower incidence of thrombotic events over time. Thus, aspirin at a low dose, either 81 milligrams or 100 milligrams daily, is a mainstay of therapy of patients with polycythemia vera. As well, therapeutic phlebotomy is a major intervention in the management of patients with polycythemia vera. Recent data has established a threshold below which patients' hematocrits should be kept in order to optimally reduce their risk of having a cardiovascular event. In this particular case, the use of a hematocrit of less than 45% represents the current standard therapeutic goal with regards to phlebotomy. Cytoreductive therapy may also be employed in the management of patients with polycythemia vera. Cytoreductive therapy is often utilized if patients are deemed to be at high risk of a thrombotic event, if they have frequent phlebotomies or have poor tolerance to phlebotomy, if they have symptomatic or progressive splenomegaly, if they continue to have severe disease-related symptoms, and if they have marked leukocytosis or thrombocytosis. There are several different agents that may be used for cytoreduction. Hydroxyurea is often used as a first-line cytoreductive agent. Data has indicated a lower risk of thrombosis in patients treated with hydroxyurea as compared with phlebotomy in at least one study. As well, hydroxyurea can be useful to control myeloproliferation and organomegaly. There has been concern raised about leukemogenicity in the use of hydroxyurea. However, several studies have not supported an association between leukemia and the use of hydroxyurea. Interferon has also been widely used as a first-line cytoreductive agent. Data has demonstrated in several different studies that use of interferon is able to result in hematologic complete remissions. In general, interferon therapy has been well tolerated, with the discontinuation rate demonstrated on the right hand of this figure. More recently, the use of ruxolitinib, a JAK1/JAK2 inhibitor, has been evaluated in patients who had inadequate response to hydroxyurea, or intolerance to hydroxyurea. Patients who received ruxolitinib as compared with best available therapy had improvements in their hematocrit control as well as the size of their spleens. This represents a new intervention available for patients with polycythemia vera who have not responded adequately enough to hydroxyurea. This gives us a sense of the approach to patients with polycythemia vera currently. However, there are a number of open questions that still remain. We know that therapeutic goals in the treatment of PV are focused really on reducing the risk of a thrombotic event and on the symptom burden. Low-dose aspirin and phlebotomy are often used in the initial management of patients with PV, but some patients do require cytoreductive therapy. However, we do not yet know what is the appropriate order of first-line agents that should be used in patients who require cytoreductive therapy. As well, the correct order of agents to be used in second-line therapy has only begun to be addressed thus far. Thus, we do have several questions that remain to be answered in the approach to treatment of these patients. Thank you for your attention.